Hi, I'm Aileen Farrick, nurse practitioner at NYU Medical Center in Manhattan, New York. And I'm going to discuss today identifying AFib risk factors. Can patient outcomes be managed? So some background about atrial fibrillation. It affects over 2 million people in the United States and 6 million people in Europe. It's been estimated that the cost of caring for AFib patients is $6.6 billion US per year. And based on current incidence of AFib, it's been estimated that by the year 2050, there'll be over 15 million people who will experience AFib. So atrial fibrillation is said to be reaching epidemic proportions. The impact of that explosion is quite significant. As we see here, when we're between the ages 60 and 70, the more risk factors we have, the higher it impacts our risk for stroke and death. So it becomes very important for us to be able to identify risk factors and modify them to reduce the incidence of AFib. So how do we know what those risk factors for AFib are? So some of the sources have been three particular epidemiologic studies. One was the Framingham Study that was sponsored by the Department of Health. It was conducted in Framingham, Massachusetts, with over 5,200 participants. The objective of the study was to look at hypertension and cardiovascular disease, looking over 3 decades, starting in 1948. In 1971, they included the offspring of those original participants. The second study is the Olmsted study that was conducted out of the Mayo Clinic. It was a retrospective study looking at the incidence of AFib from 1980 to 2000 to determine future prevalence, and it looked at over 4,600 patients. The third one is the Cardiovascular Health Study that was sponsored by the National Heart, Lung, Blood Institute. It was a prospective study that was trying to determine risk factors for coronary disease and stroke, initiated in 1991 with, again, over 5,000 patients studied. So some of the known risk factors that were identified out of those studies are as follows. This is particularly from the Framingham study, looking over 3 decades. And as we see, age is a significant risk factor, more in men than in women, with men who initially were enrolled in the study having a 3.2% incidence, and after 3 decades, over 9%. White males had the greatest risk as far as race and ethnicity. We see that hypertension and diabetes have a significant effect, and even more so, coronary disease and MI in men as greater than women. Heart failure for men is a 5-time greater risk for developing AFib over the course of this study, and for women, almost 6 times the effect. And as we see, valvular heart disease also has significant risk related to atrial fibrillation development. So as we see, some of these are not modifiable, but we should focus on those that are modifiable so that we can reduce that incidence. If we look at, again, the age factor, the older we get, the higher our incidence of developing AFib is. If we look at race and ethnicity, again, white males have the highest incidence. But if we look at the study population, we see that there was a low percentage of other ethnicities contributing to the study. We compared gender and ethnicity. We see that, again, white men, most prevalent, and then white women, and black men were pretty equal in their risk. If we look at the Northern Manhattan study, where Hispanic populations were also included, again, we see that the incidence for white males is still of highest prevalence. If we look at hypertension and how that relates to atrial fibrillation, we know that it activates the renin-angiotensin system. Angiotensin II will increase our blood pressure and cause vasoconstriction, which will then increase filling pressures, increase wall stress, affect atrial ion currents and refractoriness. It directly impacts atrial fibrosis. As we treat hypertension, I should backtrack and say if we treat hypertension with ACE inhibitors and ARBs, we can impact the renin-angiotensin system and therefore reduce atrial fibrosis, reduce left atrial size, reduce left ventricular hypertrophy, and modulate the sympathetic nervous system that all contribute to the development of atrial fibrillation. If we look at congestive heart failure as a risk for AFib, we know that heart failure and AFib coexist. So does AFib contribute to worsening heart failure, or does heart failure contribute to worsening AFib? If we look at the mechanism pathophysiologically, we see that heart failure increases filling pressures and activates, again, the neurohormonal system, which then directly impacts the atrium by causing fibrosis as well as the ventricle. And the left atrial size increases, we develop AFib. If those rates are rapid and the loss of atrial synchrony will then contribute to further AFib, and it becomes a vicious cycle. So how do we treat the congestive heart failure to reduce the incidence? Well, there have been a number of studies, heart failure studies, and as we see, treating with either ACE or ARBs, ACE1 or ARBs, significantly reduces our risk for developing new onset AFib. What about diabetes? We do know that that has a significant influence over developing AFib, but we don't know specifically why. This particular study, which was recently published online as an abstract, looked at the association of diabetes related to the duration of living with the condition and glycemic control for how it impacts AFib. Over 1,400 patients were represented, and as we see, they found that compared to controls, the overall odds ratio of developing AFib is 1.4 for diabetic patients. The duration of diabetes increases the risk of AFib by 3% for every year of living with diabetes. And as we see here, the hemoglobin A1Cs, which sort of regulates glycemic control, we can see that we have closer to a 2-time increased risk if our hemoglobin A1C is elevated. So those are sort of the known risk factors that came from the Framingham study. Now there are some novel risk factors that I'd like to review and its impact on AFib development. So if we look at the guidelines as defined by the World Health Organization, we can see the criteria for BMIs related to whether we have normal weight. If we're 25 to less than 30 with the BMI, we're overweight, and anything over 30 is considered obese. So there were a couple of studies that I'd like to review, looking specifically at the role of obesity as a risk factor for AFib. This was an integrative review that looked at a total population of over 123,000 people. And as they found, obesity increases the risk of AFib by 49%. Interestingly, though, being obese, so increased BMIs, does not impact the development of AFib after cardiac surgery. This particular study, which was a cohort study of the Framingham, found that there was a 4% increased risk of AFib for every increased unit of BMI, and that obesity related to AFib may be mediated by left atrial size. So if we're obese and we have increased left atrial size, that will impact on the development of AFib. As we know, increased BMIs also has a major relationship to obstructive sleep apnea. And we know that now that obstructive sleep apnea contributes to the development of AFib. How does that mechanism work? Well, if we see that obstructive sleep apnea causes increased hypoxemia intermittently during the night, it increases CO2 retention, and it activates the sympathetic nerve system, also increased fluctuations of blood pressure. So there are a couple of studies that looks at the incidence of obstructive sleep apnea in patients with AFib. Here, GAMI, published in Circulation in 2004, showed that there was 49% of patients with obstructive sleep apnea compared to 32% of controls developed atrial fibrillation. In knowing whether treatment of obstructive sleep apnea can impact the reoccurrence of AFib after cardioversion, 39 patients were studied by this group, and they saw that if you're treated for AFib, the incidence is reduced half of compared to those that were untreated. So here, as we see, those that have atrial fibrillation have an increased incidence of sleep apnea as compared to those who are just followed in general cardiology. So we know clearly that obstructive sleep apnea does impact your risk for atrial fibrillation. Another novel risk factor that we're currently looking at is inflammation as it relates to AFib. C-reactive protein is a vascular, inflammatory, and cardiovascular marker. But the relationship of CRP to AFib is uncertain. Does the initiation of AFib activate inflammatory effects, or is it the opposite effect, that the presence of pre-existing systemic inflammatory state promotes persistent AFib? The Cardiovascular Heart Study had measured C-reactive protein at patients at baseline, and it did predict that it would be associated with AFib. It was a good predictive indicator. A more recent study that was just published in Heart Rhythm in 2010 was trying to tease out whether it was which came first, the chicken or the egg, the inflammatory effect or the AFib. So they took samples of blood from both intra and extracardiac chambers, and they measured CRP as well as interleukin-6, which is another inflammatory marker. And they found that there were increased inflammatory markers, the CRP and the interleukin-6, as they drew the AFib for those patients. They drew the blood as those patients were in AFib from their intracardiac chambers. So their feeling was that AFib, the development of AFib, leads to a sequestration of inflammatory cytokines that then cause atrial remodeling and then promote further AFib. Future studies are needed for us to better understand the significance and predictive value of CRP to AFib. It is felt that statins, ACE1s, and ARBs may contribute in reducing that inflammatory effect. A very controversial risk factor to discuss is alcohol consumption as it relates to AFib. Past studies that were done in the late 70s and 80s described holiday heart, but it was never really determined whether it was the consumption of the alcohol or the actual withdrawal after binge drinking that may have contributed to the development of AFib. Typically, patients would come in after partying or holiday season to the emergency in atrial fibrillation. Epidemiologic studies have been done, but the results are not consistent. There have also been some animal model electrophysiologic studies trying to induce atrial fibrillation electrophysiologically in mice that were intoxicated, and they were not able to induce the atrial fibrillation. So if we look at some of the data from the Framingham Study, where they look to measure the amount of alcohol, we see that the relative risk is actually increased for those patients that drink greater than 36 grams per day of alcohol. But if patients are drinking 0 to 12.1 to 24 grams per day, there is no significant increase in the development of AFib. So it may be related to the amount that is consumed. On the other hand, the Cardiovascular Health Study looked at amount of consumption and type of alcohol that is consumed. So they looked at beer, wine, and spirits for those that drank 0 to 7 drinks per week. Again, 1 drink a day is a lot different than 36 grams that was described by the Framingham Study, but they found that there was no significant difference in the development of atrial fibrillation on the type of alcohol drank and the amount. Psychosocial factors contribute to atrial fibrillation. This particular study looked at anger and hostility in the Framingham Offspring Study. They looked at over 3,800 patients, and they found, based on questionnaires, that those who had exhibited trait anger, hostility, and symptoms of anger had a significantly higher risk for developing atrial fibrillation. And in fact, those that also exhibited trait anger, sorry, this is in the wrong box here, also contributed to total mortality. If we look at another study that was conducted by Mattioli and published in Europace, he measured acute life stress and type A behavior and found that those that scored high in type A behavior scores, questionnaires, had a significantly increased incidence of developing atrial fibrillation. These were lone AFib patients. And if we look at the high life stress score, again, those that scored very high with stress had a significant increased incidence of developing AFib. In fact, those that scored in the two highest stratas of the life stress scores had a twofold increased risk of AFib, which tells us that perhaps we should be contributing to modifying by behavioral modification our patients' behavior and personality types so that we can reduce the risk. Newer developments for finding risk for atrial fibrillation are related to genetics. So is AFib familial or is it associated with gene mutation? As we look here at Pedigree, 3 different pedigrees of families, we see that it is familial. And as we saw recently in a study that was published in the Journal of the American College of Cardiology, there have been genes that have been associated and identified with AFib, including the KCNQ1. We know that it affects the potassium channel, and it can also be associated with long QT. Others that have been implicated and will be continue to be studied are the KCNE2, the KCNJ2, and the KNE5. We do know that the KCNQ1, the calcium channel mutation, results in decreased atrial action potential duration, decreased effective refractory period, and then the development of atrial fibrillation that is consistent with the wavelet model. So in summary, I would like to conclude by saying that we know a lot about atrial fibrillation and its risk factors, but we need to learn more, specifically with these new novel risk factors that have been identified. We need to learn how to better treat these risk factors for reduction of the incidence of AFib, and we need to change and modify people's behavior, such as weight loss and perhaps some behavior modification for temperament, so that we can help promote a reduced incidence of atrial fibrillation. Thank you. Stop recording.